record. We're connecting to the server. Okay, we are ready to go.
So I just say continue, and then I can start, right?
Yes.
Okay. All right. Well, good morning to everyone. For those who are not familiar with me, I'm Andrea Bonny, the Chief of the Division of Adolescent Medicine at Nationwide Children's Hospital. And this morning, I'm going to be speaking on the topic of ethical challenges and special regulatory requirements of including adolescents in research. I would like to acknowledge Brittny Manos, who's the research coordinator in my division, who actually helped me compile the information that I will be presenting today. So the objectives for this presentation, one is I'd like to review the ethical principles of research that really affect research with every participant, including minors. I'd like to consider ethical uncertainties around adolescents' ability to consent to research participation, and then understand the ethically appropriate situations where waiver of parental consent would be okay. So we're going to start with the case. We have a 17-year-old female, and we will call her Sarah. Sarah desires to enroll in a study evaluating weight gain and bone mineral density changes among adolescents who have selected to use the contraceptive implant. She has consented to the medical placement of the implant and desires now to participate in your study. However, the institutional IRB has required that for participation in the study that consent from one parent would need to be required, and neither Sarah's mother or father is willing to provide this informed consent. And so I'd like you to consider Sarah's situation as we go through our slides this morning. And we're going to get back to Sarah at the end and have a little discussion around the issues related to her. Okay, so to review, the ethical principles of research. We have 4 ethical pillars. One is respect, which is the recognition of a person as an autonomous, unique, and free individual who has the right and the capacity to decide. Beneficence, which is really acting in a way to benefit others while promoting their welfare and safety. Non-maleficence, which is purposely not purposely causing harm, excuse me. And justice, which is the fair selection of research participants. And these principles apply to all research, including research involving adolescents. When we think about adolescence, broadly, adolescence has been considered to extend from really the onset of puberty, which could be as early as 7 or 8 for some individuals, to relative independence from parental control, which some could argue is up to the ages of 25 or 26 years of age. But the term adolescence as used in this presentation is going to refer to individuals who are approximately from 9 to 10 years of age and up to but not including the age of 18, because by the age of 18, generally that is considered the age of majority, and individuals are allowed to provide consent for themselves for participation in research. So a little background, in 1998, the NIH called for increased representation of children and adolescents in research. And really, why did they do that? Well, prior to that, investigators and IRBs tended to interpret the 1947 Nuremberg Code, which had the requirement for informed consent, as implicitly excluding children. And really, this was on the basis of their limited intellectual and emotional capacity. So until the 1960s, IRBs really allowed clinical research with children only when that intervention offered a potential benefit over standard therapy, and that really tended to be in things such as cancer trials. More recently, in 2002, we had the Best Pharmaceuticals for Children Act passed, which really intended to promote research in children and adolescents. That act was reauthorized in 2007, and they gave it a little more teeth in the reauthorization. In the reauthorization, the FDA was allowed to issue specific requests for manufacturers for research in children and adolescents. And then this was followed by the Pediatric Research Equity Act, which actually mandated pediatric testing, specifically of drugs that were likely to be used in the pediatric and adolescent population. So we have had movement forward. But despite this movement, adolescents continue to be underrepresented in research. And I think really the reasons behind this is there are several issues. One is researchers and IRBs alike struggle with interpreting federal regulations as they apply to this patient population. And so the federal regulations that we follow for clinical research, 45 CFR, 46, those same regulations apply to research with adolescents. Where the variation falls is in the interpretation, particularly regarding the following two issues, which is the capacity of an adolescent to provide informed consent and the protection of confidentiality for that adolescent, especially in sensitive or controversial issues such as sexuality or illicit drug use. If we look at adolescents and parents' views, we find that there's also little disagreement there. This study was published in 2003, and what they did is they actually put forth these research scenarios to parents and to adolescents to see whether they'd be willing to participate. Well, what they found was that there was agreement. 74% of the time, adolescents and their parents agreed on their willingness or unwillingness to participate. Where they disagreed, however, was that they both claimed that they should have ultimate responsibility for that participation decision. And so, hence, a little bit of discrepancy here with regards to adolescents and their parents' views. So we're going to first focus on informed consent. So in the research setting, consent is called informed consent. And the reason for that is that there are three essential elements. One is informed. It is the responsibility of us as researchers to fully inform potential participants of the description of the nature, the duration, the purpose of the research, its methods and means, and all reasonably expected inconveniences and hazards. The consent also needs to be voluntary, which that means there has to be no element of coercion in that decision. And the individual who's providing that consent has to have capacity, which is the ability to really appreciate the risks and benefits. And it is around these two last issues of voluntary nature of the decision and capacity where an adolescent's ability to consent can and has been questioned. So traditionally, for participation in research, Ohio law and federal law requires that we obtain parental consent for anyone under the age of 18. And it is generally accepted that for younger children, that they really do not have that decision-making capacity and that parental consent is and should be required. But the picture becomes less clear when we look at adolescents. As I mentioned, voluntariness implies that an individual understands that to which they are consenting and that they do not feel vulnerable. And in the absence of voluntarism, one wonders whether an adolescent can provide true informed consent. So some questions to consider. Is it possible for voluntary consent to be obtained even in the absence of full understanding? Is an adolescent child particularly vulnerable to parental or other authority? And are there actually specific situations that exist where that would place an adolescent would make an adolescent particularly vulnerable, such as examples of when they're under like duress for mental or physical illness? So Ascent has been put forth as a solution to this adolescent sort of gray area. So Ascent recognizes that children and adolescents may have some limited capacity and decision-making abilities. And some have suggested that Ascent be the standard for anyone under the age of majority. Ascent addresses this sort of middle ground. It is in between what we call autonomous full consent and no involvement in the consent process at all. However, it's important to point out that Ascent is the process of agreeing with someone, concurring with someone to agree to treatment or involvement in the research, but it does not entail a demonstration of understanding or of reasoning ability. At Nationwide Children's Hospital, the IRB actually requires Ascent from a minor participant starting at the ages of 9 and up to, but not including the age of 18. And I think that's pretty standard. I think you'll find that it's usually around the age of 9 where minor Ascent is actually going to be required. Now, there are some scholars, though, who believe that assent is not sufficient. I'm going to quote Loudon. Loudon actually wrote that childhood belongs to children least of all, and its study remains largely a study of adults' attitudes to and practices concerning children. Even when the criterion of competency is met, a child's right to exercise control over his or her own destiny has been negated by the courts. And adult beliefs regarding children's rights influences children's opportunities for self-determination. And they go forth and asking the question, is it ethically correct for adolescents to be considered still the property of their parents? Others have pointed out that assent does not actually equal dissent. So if we allow adolescents to assent, but we do not also provide the ability to dissent, then we are effectively giving them no decision-making power at all. So dissent is defined as an objection to participation, and it could be argued that if assent is going to be honored, then we have an ethical duty also to honor dissent. And by the present standards for adolescents, really the right to consent appears not to be balanced by the right to withhold that consent. Because if you look at our language and our assent documents, they are really couched in the language of assent and rather than dissent. So with that, let's consider the capacity of an adolescent to provide informed consent. There's been a couple of studies I'd like to review, and one study that examined the relationship of understanding of the research participation to anxiety control and stage of cognitive development among a cohort of children and adolescents who were in an inpatient setting. And what they found was that the knowledge of research participation was actually related more to the emotional aspects of control and anxiety than to the age or the cognitive development of that child. What that meant was that in situations where children and adolescents were less anxious and they felt more sense of control, their knowledge of research participation was higher, and that we really should work to creating situations that are less stressful and have an element of control in order to help adolescents provide informed consent. In another study done by Laura Dorn and her colleagues, they actually used the test of understanding, which is more consistent with the law of informed consent. And this study included children as young as 9 years of age and up to 21 years of age. And what they found is that 14-year-old adolescents did not differ from young adults in their ability to understand the research. And so suggesting that adolescents as young as 14 might or probably have the capacity to provide informed consent. With regards to vulnerability, it is important to note that free consent may not actually be possible when others hold the balance of power. And vulnerability is defined as that sort of incapacity to protect your own interest, and that arises from being a junior or a subordinate member. So clearly that would pertain to minors and adolescents. And this position of dependence and vulnerability really could be experienced in any controlled setting, but it may actually be even worse in situations of crisis, which would further impede an adolescent's ability to consent. However, it's important to note that this belief that adolescents are highly vulnerable and easily influenced is not really supported empirically by evidence. And it should also be noted that when adults are hospitalized as inpatients, they're also considered to be dependent and hence vulnerable to a degree, but their right to provide consent is not invalidated unless there are other circumstances such as they're found to be incompetent. So some have put forth as the gold standard for consent for adolescents in research is what's called a relational narrative consent. And that states that the role that adolescents ought to have in research consent is in giving consent to the best of their ability. And that ability should be assessed by the researcher and the adolescent in partnership through what's called sort of a relational intersubjective process. And this could range anywhere from assent to consent. They propose this as a case-by-case assessment of capacity and vulnerability, and that even those who are not competent to consent for themselves, they are still owed the respect, justice, and inclusiveness to participate in the Ascent process. So theoretically, that really would be a gold standard, but I think in practice that is really difficult to make a reality, and really difficult for, I think, IRBs to manage this as a gold standard. However, there are ethical situations where waiver of parental consent is allowed. So in 1997, the National Commission for Protection of Human Subjects actually recommended that individual IRBs be allowed to determine that parental permission be not required in certain research studies involving adolescents. There are really three areas where it's ethically appropriate to waive parental consent. And these are outlined below. So one, when requiring parental consent is not a reasonable requirement to protect the adolescent. Two, when the waiver would not adversely affect the right and welfare of the adolescent. The study poses no more than minimal risk, and the study could not be practically carried out without that waiver. And finally, in certain studies involving pregnancy, treatment of sexually transmitted infections, contraception and abortion services, an adolescent can provide consent and parental permission is not required. And on the next slide, we're going to speak a little bit more about those situations and why that's the case. But I would like to point out the reference on the bottom of this slide. This was the Committee on Adolescent Healthcare from the American College of Obstetrics and Gynecology. They published this committee opinion in June 2016, and it really provides a great rationale and justification for when waiver of parental consent can be justified and requested. And actually, Nationwide Children's IRB uses this document when they make decisions around waiver of parental consent. So it's a really good resource for researchers who are looking for some guidance. So with regards to those specific situations, if you read the federal regulations governing research, children are actually defined as persons who have not yet reached the legal age for consent to the treatment or the procedure involved in the research under the applicable law of the jurisdiction in which that research will be conducted. So it's really important for researchers to understand state laws around the age of majority, emancipation, and minor consent. And I would say generally, most states will give adolescents the consent, the ability to consent for medical care when it comes to contraceptive services and treatment of sexually transmitted infections. And so, according to federal regulations, in those settings, it may be justified and okay to allow the adolescent to provide informed consent to studies that pertain to those topics. Do want to mention, though, that for people who are going to conduct research in a school setting, that school settings, there are further regulations. There are federal education laws that govern research conducted in those school settings. And so researchers who are going to work in that area really need to understand those laws and abide by them as well. Okay, so let's go back to our case. So we had Sarah. So Sarah actually consented for the placement of the contraceptive implant. She wants to participate in an observational study. There's no intervention. They're going to monitor her weight and her bone mineral density. So there's some risk with the exposure maybe of a DEXA scan, but minimal risk. And but she would like to participate, and her parents are not willing to provide informed consent, which has been the requirement by her IRB. So if we look at our pillars, our ethical pillars of research, I could argue that in this case, we are, by requiring parental consent for this study, we are not respecting Sarah's ability to be an autonomous individual and make decisions for herself. We're certainly not being just. We're not allowing her just participation in research. And you could even argue that we may not have abided by non-maleficence, because, for example, if her parents were not aware of her contraceptive decision, and the reason they became aware was because they were approached for her participation in a research study, we may have unintentionally caused some harm to Sarah. If we look back at that federal definition of children, so in the state of Ohio, Sarah has been granted the ability to consent for the medical procedure for the placement of the contraceptive implant. So in this situation, it would be reasonable to allow waiver of parental consent for her participation in this observational research study. Another document I'd like to make you all aware of is the Society for Adolescent Health and Medicine Consensus Guidelines for Adolescent Health Research. They were initially published in 1995, and then they were republished in 2003. And they really review consensus guidelines around adolescents' participation in research. In summary, they state that adolescents generally exhibit cognitive capacity to provide informed consent equal to that of young adults, that the content and wording of consent forms for adolescents should resemble that used for adults, and that assent absolutely needs to be sought out even when parental permission is obtained. And their last note is one last issue I'd like to mention, which is that researchers who are going to work with adolescents need to be prepared to offer assistance to their adolescent participants when health needs are identified in the course of the research. And that includes rapid referral for adolescents who exhibit an imminent risk of harm to themselves or others. So when we think about imminent risk, this is really identical to the clinical setting where we provide clinical care. In the case where an adolescent is deemed to be of acute risk to themselves, perhaps suicidality, or to others, homicidality, we in those situations have a duty to warn or to disclose to an appropriate authority or legal guardian. What I would say is that it is really the minority of research situations where this actually is applicable. And if you are going to be conducting a study where you think issues of suicidality, for example, may be disclosed, then it would be appropriate in your consent to mention to the adolescent that if in the situation where that is disclosed or uncovered, what your process is and to whom you will be reporting, so that they are knowledgeable of that prior to choosing to participate in the study. And we do that in clinical care all the time. We explain to our patients when we have the duty to warn so that they are cognizant of that when they disclose information to us in the setting. And finally, if you have someone on your team who's comfortable with adolescent health care, they can really help you work through many of these issues. So in summary, adolescents are capable of greater involvement in the research consent process than is the norm. They should be treated with respect and dignity. Increasing their involvement in research has the potential to enhance their growing autonomy and capabilities. And I love this statement. This can be achieved in an environment in which protecting them from harm does not also mean preventing them from decision making. I think that's a fantastic statement, and I am not responsible for it. I found it. So our responsibilities are to protect our adolescents, to advocate to ensure that their voices are heard, to develop even more policies around adolescents' involvement as human research participants, and really to work to facilitate their meaningful involvement in our research endeavors. Thank you all very much.